emerged as a public health priority because it causes the devastating economic burden on families and nations. Worldwide, around 50 million people have dementia, with nearly 66% living in low and middle economic countries. Elderly population has increased over 70% in the last 2 decades in Bangladesh. And with it, the number of people at risk of dementia has too increased. Unfortunately, we did not have any data on burden of dementia until recently a groundbreaking national survey conducted in collaboration of National Institute of Neuroscience and ICDDRB. I'm sure today's highly experienced faculty will shed light on this urgent health matter. I would humbly request to the audience to keep themselves muted and keep their video off during the session. The session is being recorded and you can share your question or thoughts in the chat box. Now it is my immense pleasure to invite the living legend of neurology Bangladesh, our respected teacher, renowned neurologist, Professor Dr. Kaziuddin Mossa, Director, National Institute of Neuroscience and Hospital, a national expert in clinical research and a policymaker, to deliver his welcome address. Professor Kaziuddin Mossa, please.
Thank you, Dr. Professor Zahid. Good evening, everybody. This is Dr. Kaziuddin Mohammed, Professor of Neurology and Director, National Institute of Neuroscience, Dhaka. Great to meet all of you. At the outset, I convey my regards to the chief guest, Professor Khurshid Alam, Director General of Health Services, Government of Bangladesh, and today's chairperson, Professor Ruby Amin, Director, National Center for Non-Communicable Disease Control, and Dr. Tahmid Ahmed, Executive Director, ICDDRB Dhaka, for their presence in this August session. We are also honored by the presence of two international experts, Professor Dusum Stephen, who is the Professor of Neuroepidemiology and Global Aging, University of Nottingham, and Professor Trudy Lang, who is the Director, Global Health Network, University of Oxford. And I'm sure that their participation will bring this session to an international scale. We're also enriched by the presence of very eminent professors of this country, Professor Anisul Haq, Professor Qazi Tariqul Islam, Professor Budri Alam, Professor Rizvi, Professor Hassanul Zaman as a panelist. I would like to extend my warm welcome to all of those guests. I do really appreciate all for attending this seminar to short notice. Respected participants, the schedule of the session will focus on the topic dementia. It will also include issues like burden, demography, current healthcare system, and future perspective in the context of our country. In the next few minutes, after I finish, I will be walking you through what the conference is about and now how the importance it is. And I am sure from the presentation and lovely discussion and interaction will make this session more useful and fruitful. With these few words, I would like to conclude and thank you and best wishes for all of you. Thank you very much.
Thank you so much, Professor Kaziuddin Mossa, for your welcome address. Now we are going to start a scientific session. Today's we will have 3 speakers who will present the study findings of National Dementia Survey and global perspectives of dementia. Dementia from a global perspective, and future implications for Bangladesh. Now I would like to invite Professor Blossom Stephen, Neuroepidemiology and Global Aging, Institute of Mental Health, University of Nottingham, UK, to start her presentation to give us the global picture of dementia. Professor Dr. Blossom Stephen.
Oh, wonderful. Thank you so much for the kind welcome. And it's a real honor to be here with such a distinguished panel of speakers. So I'd like to say thank you very much. I thought I would start this session by presenting some population statistics on dementia. So we know dementia is a public health priority, and as already been said, over 50 million people have dementia worldwide. And this number is expected to rise to 152 million by 2050. We know that currently the majority of people with dementia live in low and middle income countries. And by 2050, this is expected to rise to a percent of 71%. This is a concern because it's typically these regions that have minimal, if any, infrastructure and budget allocated to population aging and dementia. In 2019, Alzheimer's disease and other dementias was the 7th leading cause of death. And the global cost is significant, estimated at $1 trillion in 2018, and is expected to double by 2030. But what we see disparity in terms of where costs are incurred, with the majority of costs incurred in high income countries. This is not unexpected given the low wages in low and middle income countries, and the fact that in low and middle income countries, the majority of care is provided by unpaid volunteer carers, a majority of families. However, the picture is not all negative. Oh, I can't get it to press my slides. Here we go, sorry. The picture is not all negative. Indeed, research on generational effects, or what we call cohort effects or time trends in dementia risk, show that dementia risk is actually remaining stable or even decreasing in some high-income Western countries. So the figure on the screen shows the results of a systematic review that we conducted in 2019, where you've got year on the x-axis, and then you've got country and location of study on the y-axis. And what we see is that over time, dementia risk has increased in some countries, as shown in red, like Japan and France. However, what we do see is we also see a lot of stability in dementia risk, as shown in blue, and even decreases in dementia risk, shown in green in countries like the United States and the UK. So this suggests that at least part of dementia is modifiable. What the results did show was that there was an absence of data from low and middle income countries, with the exception of China. So a clear research gap there. Also, we don't know what is driving the changes in dementia risk, although it is hypothesized that increased educational attainment in later compared to earlier born generations, as well as better control of cardiometabolic risk factors like control of hypertension and diabetes, might be driving changes in dementia risk, and in particular, the decline in dementia risk. So what about dementia risk factors? We know that dementia is a complex disease that's often the result of a combination of genetic, environmental, and lifestyle factors that occur across an individual's life course from birth all the way up to older age. So key protective factors are educational attainment and social engagement, and lifestyle factors around increased physical activity and good diet. And risk factors are the key risk factor being aging, as well as genetics, such as the presence of the apolipoprotein E4 allele, cardiometabolic and cerebrovascular disease, so hypertension and a history of stroke, we know are risk factors, as well as key environmental risk factors, such as exposure to air pollution and pesticides. So what can we do with this risk factor information that we have? So how can we modify dementia risk? So in 2017, with an update in 2020, the Lancet commissioned dementia prevention, intervention and care. And here are the results from that commission. So on your right-hand side of your screen, you can see the river of life here with different life stages, birth, showing the genetic risk. So again, that apolipoprotein E4 allele converting 2 to 2.5 times risk. And then you've got early life risk factors, midlife and late life risk factors. So if we look at early life, the results suggested that approximately 8% of new dementia cases could be attributed to low educational attainment in early life. When we move to green, to midlife, we see that approximately 9% of dementia cases could be attributed to hearing loss, midlife hearing loss, and then other risk factors in the midlife bubble were hypertension and obesity. And then when we move up to later life, we see the key risk factors, modifiable risk factors there are smoking, depression, physical inactivity, socialization, and diabetes. And when all these 9 risk factors are added up, that accounts for approximately 35% of dementia cases. If we add traumatic brain injury, alcohol misuse, and air pollution, then the potential for dementia risk reduction increases further to approximately 40%. So if we remove all these 9 risk factors, we could potentially eliminate 40% of dementia cases, which is quite significant given such a large number of the population has dementia. However, despite these results, the World Alzheimer's Report in 2019 found that across the globe, 1 in 4 people still believe that there's nothing that can be done to modify their dementia risk. So this really highlighting the need for public health campaigns driving education around dementia and dementia risk reduction. When we look at the same analysis being conducted in lower middle income countries, we see that the potential for risk reduction is actually even greater in these settings. So this is data from the 1066 study. In red, we've got Latin America. In blue, we've got India, and in green, we have China. And you can see that if we eliminate all 9 risk factors in Latin America, we could possibly eliminate 56% of dementia cases. Again, in India, the same 9 risk factors, we could eliminate 41% of dementia cases, and in China, 40% of dementia cases. And this is really exciting because it highlights key targets for dementia risk reduction and dementia prevention. Right, so what is the vision for the future on the back of this? So in 2017, the WHO released their Global Action Plan on the Public Health Response to Dementia, 2017 to 2025. And in this plan, they identified 7 key priority areas, and they're here on the slide now. So the first one was dementia as a public health priority, and the objective here was to really get each country to develop their own national plan focused on targeting dementia. The second is dementia awareness and friendliness. So the objective here is to create public health campaigns, educating the population on dementia and dementia risk factors. The third is dementia risk reduction. So the target here is a 25% reduction in premature mortality associated with dementia. The fourth is dementia diagnosis, treatment and care. And this is really about driving early diagnosis and development of care pathways for people once they've got a diagnosis. The fifth is support for dementia carers. And this is around education and providing support across all stages of dementia. The sixth is around information systems for dementia, and this includes generating data every 2 years on key dementia statistics, such as the number of people who have dementia or prevalence, incidence of dementia, and key risk factors in the population. And the last one is perhaps the most ambitious, which is over the 8-year period from 2017 to 2025, double the output of dementia research. And we know that while this is exciting and provides a base for many countries' plans for dementia, it doesn't come without challenges, particularly in lower middle income countries that often lack the budgets and the infrastructure to implement such a grand plan, but a great starting point. Right, so in the last slide, what I thought I would do is I would look at the implications for Bangladesh and identify possibly 5 key targets, which I guess we can discuss. So the first target really is creation of a national dementia plan. You've got the evidence from the National Dementia Survey, which will be presented later today, and also partnerships between research institutes, non-government institutes, non-profit institutes, around funding for budget, for research, particularly in dementia and older age population, infrastructure in terms of health-seeking behaviour and pathways of care. I don't think we can avoid the impact of COVID, given that preliminary data seems to suggest that there may be an impact on cognitive health. And the last one is training and exchange programs, both nationally within Bangladesh, as well as internationally, say with institutes such as Nottingham University here in the UK, which would be delighted to partner with exchange programs. And I guess the overall goal is really to reduce the impact of dementia on the people from Bangladesh. So excellent. Again, thank you for the invitation and of the opportunity.
Thanks to Professor Dr. Blossom Stephen for our wonderful presentation. Now I would like to invite two eminent scientists, Dr. Alia Nahid, scientist of and head initiative for NCD ICD-RB, principal investigator of National Dementia Survey, and Professor Dr. Malia Hakim, Department of Neurology, National Institute of Neuroscience and Hospital, Bangladesh, co-principal investigator of the study to present burden of dementia in older age people and healthcare seeking in Bangladesh. I would request Professor Dr. Malia Hakim, Madam, to start the presentation on burden of dementia in the older age people. Dr. Malia Hakim, Madam.
Give me the opportunity to present on this webinar. I will focus burden of dementia in older age people in Bangladesh. First of all, what is dementia? Dementia is a syndrome in which there is deterioration in memory, thinking, behavior, and the ability to perform everyday activities. Let's view the global data of dementia. The total number of people with dementia is projected to reach 82 million in 2030 and 152 million in 2050, according to WHO 2020. Death from dementia-related disease has increased from 1.02 million in 1990 to 2.44 million in 2016. There is no national level estimations of the burden of dementia in Bangladesh till before, but one community-based study was done in rural Matlab, which reported 15.1% prevalence of dementia among rural population. The primary objective of this study was to estimate the prevalence of dementia among older people at or above 60 years in rural and urban areas in Bangladesh. And then the secondary objectives was to explore the health status, care-seeking pattern, and support system for older people living with dementia in urban and rural communities in Bangladesh. The methodology, the study design was cross-sectional study, and included people who are aged at or above 60 years, who were living at least 6 months at the study site, and who have given the written consent. Who were too ill to commute has been excluded. Among the 8 divisions, from the 7 divisions, Dhaka, Chittagong, Khulna, Borishal, Rajshahi, and Rangpur, and Sylhet, data was collected, and then randomly from 1 ward for each division, 1 village for each division. There are 7 rural urban wards from where data was collected. The number of households listed was 3,201, and the number of eligible elderly identified was 1,248, and the number of randomly recruited was 896. And the household listed from 7 rural villages was 6,197, and the number of eligible elderly identified was 2,943, and the number of randomly recruited person were 1,900. So the total participants were 2,796. Data collection represents the socio-demographic characteristics including age, sex, socioeconomic status, and marital status and area of residence, and the healthcare seeking who were reported illness in the past 6 months. Dementia assessed by the MMSE scale score, and depression was assessed by the geriatric depression scale. Blood pressure was measured by Omron HEM 780, blood glucose by the glucometer, and the caregiver burden by the Zerit burden interview. All are taken by Bangla version. Now the results. Total participants were 2,796. Mean age was 68 years and standard deviation was 7.2. Socio-demographic characteristics of the study participants, where the number was 2796, that is 2,796. Among them, 51% were female sex, 58.7% were never went to school, 24.5% were completed primary education, and 41.3% were marital in single, marital status was single. Prevalence of dementia among older people. This bar diagram shows overall prevalence of dementia is 8.1%, and female was 11.6%, 2.7 times higher in the female and highest in the northern division. Prevalence of dementia by sex. This the bar diagram showed burden in female is more than the burden in male in every division. Prevalence of dementia by age. This diagram shows overall prevalence of dementia increases with age, and more among the female. Prevalence of dementia among females doubled at every 10 years interval. Prevalence of dementia by area of residence. This diagram shows overall prevalence did not vary between urban and the rural area. Prevalence of dementia by marital status and education. This bar diagram shows higher prevalence observed among the individuals who did not have a spouse, that is 12.4%, and then individuals who were married, that is 4.9%. P-value 0.03, which is statistically significant. And the overall burden was higher among those who never went to school than those completed primary schooling, and the p-value was 0.001, which was statistically significant. Now, what will be in the future? We estimated number of individuals at or 60 years living with dementia in 2020. In 2020 was 1.1 million and 13.9 million older age people. Estimated number of individuals at or above 60 years living with dementia in 2041 was 2.4 million out of 29.9 million older age people. Now the key findings of the presentation. Overall prevalence of dementia among older people was 8.1%, and the prevalence varied across the division, with the highest burden reported in was in the northern division in the country. Prevalence of dementia did not vary between urban and rural areas. Prevalence among female participants was 2.7 times higher than the male and rapidly increased with age. Individual without having a spouse had a higher burden than a married individual. Individual with no schooling had a higher burden than those completed their education. And last of all, we can say our estimates suggest that the burden of dementia among older people will be doubled by the year 2014 in Bangladesh. Thanks, the audience. I will request Dr. Alia Nahid for next presentation. Thank you.
Thank you. Thank you, Dr. Malia Hakim. It was a wonderful presentation. and creating an excellent opportunity for me to start the second part of this presentation. So let me just take 1 second to share my screen, and I will start my talk. I just want to make sure that you all see my screen. So respected chair of the session, the chief guest, Honorable DG Sir, and the special guest and dignitaries and panelists, and of course, our favorite audience present today. Thank you very much for joining our session today. So Maliha actually talked about the background of the study and the burden component, but I want to take you to show you a little bit of the information that we have collected about the healthcare seeking and what is the comorbid condition of these patients. So I will basically look at the picture of older people, and side by side, we'll also try to compare between dementia patients and who did not have dementia. So our report suggested that older people frequently actually required some kind of healthcare need. Say, for example, more than half of the people reported they required some kind of healthcare over the last 6 months, and majority of them actually go to seek care. And we did not see any difference between those who had a condition with dementia and who did not have a condition with the dementia. These people actually went to these facilities for various reasons. And these two graphs show the varieties of health conditions they have reported to us. But the two conditions, such as febrile illness, knee joint pain, or any kind of joint pain and heart disease, these three conditions are more frequently reported by the participants among those who had dementia and who did not have dementia. And I just want to remind you that these conditions are actually reported by the patient. And when we tried to understand what is their source of health visit, and that was mostly drug sellers, and this care-seeking pattern did not vary between patients with dementia and without, or across age, sex, or area of residence in Bangladesh. But why they choose the facility? So that was a very important thing for us to know. So we recognize that in older age people, they actually look for a facility that can offer treatment at a low cost, and that is at a nearby location, and facility is of their choice. They get good treatment from there, and we did not see any variation across dementia patients and who did not have dementia. So when we, my slide does not move, so excuse me. So when we assessed hypertension, diabetes, depression, we identified that majority of the older people actually had raised blood pressure and a stroke more frequently reported. And interestingly, we found in this community, the people with dementia actually reported more about that. We found that they had raised blood pressure and they had a stroke more frequently than those who did not have dementia. When we looked at the risk factors of NCDs, we actually found that all of them actually, I mean, most of the participants actually had non-communicable disease risk factors, including use of tobacco, use of extra salt, low physical activity, and underweight was quite predominant across all people, irrespective of having dementia or not having dementia. But when we try to assess the comorbidity, we found raised blood pressure was, depression and raised blood pressure were frequently higher among patients with dementia compared to those who did not have dementia. And these conditions, our chronic conditions, did not vary across gender or area of their residence. We tried to understand what could be the cost of the treatment since they require more frequent visits at health facilities. And we found that over the past month, they actually spent about almost somewhere between more than 2,000 taka, the local taka, for the treatment. And it was higher among females than males, and in urban areas than the rural areas. But if you turn into USD, it is $29 US. But in taka, for a person who is old and not having an income, And if he or she does not have source of financing his or her healthcare, it is a lot of money. $2,400 is a lot of money. And this is what we are trying to show you. And what we found that it is medicine cost that is actually sucking up most of the health costs for these people. We are so astonished to see how they get their healthcare cost resource. Mostly they depend on the earning of their children. And we have observed, and this dependency vary between female and male older people. Females more depend on their children's earning, and while males actually had some earning either from self-saving or self-earning, we found about 30% people actually still are involved in wage earning, so that supports their healthcare. But when we looked at the dementia patients, we found that people with dementia actually depend on their children earning more than people who than others. So we try to understand if they have any financial means to support their healthcare or their livelihood. We found that in general, about 70% people get some kind of allowance either from the government facilities, either it is old age allowance or freedom fighter allowance or widow allowance. And very small number of people get some allowance from private sectors. But the majority of the older people still out of their scope of getting any financial support from any resources. When we try to understand who takes care of these people and how big is the burden, that is caregiver burden, we found that majority of the people who are in the community, either in the rural and urban areas, they are taken care by their family members, and majority of the caregivers are females. But interestingly, we found about 20% caregivers who are males. And when we look at who takes care of the caregiver burden, we identified that caregiver burden was not necessarily reported by these caregivers. So only 8% actually reported that they feel like they are burdened by taking care of their relative, either mother or grandmothers. But it was interesting to see that it is male caregivers actually complain more burden than the female caregivers. So there are a lot of information that we gathered from a study, but we just picked up at the tip of this big iceberg, and we identified that what Bloss actually presented a few minutes ago, Dr. Stefan Bloss, actually the pattern we have found in this country is not different from the global data that we just heard from her. So incidence factor is quite high in dementia patients, and they have some amount of chronic conditions that remain untreated or uncared for, and they prefer low-cost treatment, and this is one of the reasons probably they are deprived of healthcare. And people who take care of them also report caregiver burden. So what does it mean to us? Our presentation doesn't end here. Actually, our discussion starts from here. We are in 2021, and estimated population is more than 168 million. And if we look at the projection, we will have more than 201 million people in Bangladesh, and that will lead to a huge number of elderly in Bangladesh. And there will be more older people who will be taken care by a very small number of younger people. So this is a burden, but this is a challenge. But how can we convert this challenge into resource? That is the challenge with the public health specialist, and public health specialists need to work with the clinicians. I want to remind you that we need to attain sustainable development goal, and this goal actually demands that we ensure healthy lives and promote well-being for all at all ages. But are we really looking at all ages? This is a question from me to all the audience. And if we really try to control this incident prevention in older age, we can't just start treating or taking care of them when they become old. Actually, we need to introduce a life cycle approach for prevention of non-communicable diseases for everybody, from every aspect, to actually develop a comprehensive community-based intervention model engage in people from all sectors, doctors, nurses, community care providers, even the youth community or other people who should work together with the public health specialists and the health policymakers, along with the clinicians, to identify interactive model that can be provided to dementia patients and other older patients. But we cannot do it without a system, so we really want to have integrated primary and tertiary care health care in our country, considering preventive care and tertiary care level facilities to be improved. Thus, we see Bangladesh needs a very rapid solution. And if we really want to have a rapid solution, we need data. And we in order to get some intervention for our future approaches. And this is one of the main reasons we, ICDDRB, is going to develop an Asian network and unite people all over the regions and try to play a leadership role to identify solutions for very difficult problems like NCDs as well as dementia. So this was my last slide. I have some people to show my gratitude. That is the Non-Communicable Disease Control Program. My immense gratitude to the NCD who supported us to do the study and the Directorate of General Health Services. Thank you, NCD Control Program, for understanding this problem and allowing us to do the study. And I can't forget the hard work the research staff did and the participant. They actually spent a lot of time with us, giving their time, and we got tremendous support from our team in ICDDRB. And the last but not the least, I want to convey my heartfelt gratitude to the joint lead principal investigator of the study, our Honorable Professor Dr. Qazi Muhammad, who is the director of the National Neuroscience and Hospital, and my dear colleague, Dr. Maliha Hakim, professor in Neurology Department, who was a co-PI from NIMS, and my colleague in ICDDRB, Dr. Mohammed Bodrul Alam Sinha, who is a co-PI from ICDDRB. So I really want to convey my gratitude to all of you, and thanks to the audience for listening to me with patience. Thank you very much.
Thank you much to the
Yes,
both
we can hear you. Carry on, please.
for their tremendous presentation. A learned audience, now the panel discussion and questions and answer sessions. Today we have 4 eminent panel speakers. It is my privilege to welcome Professor Dr. Qazi Tariqul Islam, Professor of Department of Medicine, Popular Medical College and Hospital. He was the former professor of Dhaka Medical College Hospital, Dhaka, Bangladesh. Professor Dr. Bodrul Alam Sir, Joint Director, National Institute of Neuroscience, Bangladesh. And Professor Dr. Abu Nasser Rizvi, Chairman, Department of Neurology, BSMO, and Secretary General, Society of Neurologists of Bangladesh. And Professor Dr. Muhammad Hassanuzzaman, Head, Department of Neurology, Chattogram Medical College Hospital, for our panel discussion. I would like to request the audience to post questions in the chat box. You can raise your hand if you like to ask or give any comment. Here some questions in my chat box. From Dr. Qazi Jannatara. Qazi Jannatara, can epilepsy associated dementia, especially adult onset temporal lobe epilepsy, be an addressing issue as a modifiable risk factor in epilepsy associated dementia in this type of study? Qazi Jannatara. Can epilepsy associated dementia, especially adult onset temporal lobe epilepsy, be an addressing issue as a modifiable risk factor in epilepsy associated dementia in this type of study?
Dr. Zahir,
Yes.
can I help with this? I was expecting to have a panel discussion. We want to hear from the panel first, because we also want to hear experts' opinion and their insight on our presentation. And we probably will be a good idea to open the discussion for the audience. Can you do that, please?
Okay, first of all, I want to go through panel discussion. Now, may I request Professor Kazi Tariqul Islam sir for the valuable comment. Professor Tariq sir.
Good evening. Thank you very much. It's a privilege for me because I'm an internist, but we deal with the aged people for many reasons. Because the term population aging is a great concern globally. And of course, it is not unsuitable for Bangladesh too. So such a study that has given a lot of things that I'm coming later on that part. But as I think I have been invited here for the reason because we are trying to make the geriatric medicine on the surface as a good service corner, because in our country, the aged people are neglected, as you have seen by the two speakers, different data that their economic solvency and so many things are concerned with lot of health issues with them. And with the age, you know, the non-communicable disease, they are rising a lot. And we are trying to make a guideline for the comprehensive geriatric assessment tool, because, you know, in Bangladesh, there are not huge budget for the general people. When we will be asking for geriatric people a separate budget, I am not sure how much we will be successful in that sector. Still, our endeavor and pressure to the government will remain, and so that the alarming situation that has been mentioned by the foreign speaker, our two speaker of the study, that by 2040 or 2050, the number is coming double almost, and 72% is increasing by the coming years to come. So these are very, very important concerns. So if we consider that, for example, in this COVID situation, what happened in Bangladesh, this is just personal communication. There is no data behind it. Most of the young people, they went out, they brought the disease at home. The whole family became infected. The old people got admitted in the hospital and they died. But the young people, because of the immunity, they survived. This is the hard fact of this COVID situation. Other than the COVID, other time, the service to the older people or the dementic people, many people, they cannot afford a caregiver. It is not possible in rural setting, urban setting also, in middle class. It is very difficult nowadays. Caregiver, the money provided to them is a very important issue. On the other hand, if you consider about UK, this is again a personal communication. When in the first wave, 80 plus people, they used to come to the hospital. Doctor attended the younger people relatively and gave more attention to them, because they know if the indication for intubation is needed for very elderly people, only 20% chance of survival. So, but in total, the issue is the elderly people are always neglected. Where there is facility, where there is no facility. My concern for one issue regarding the dissemination of this data, I have one or two things that I kept a note. I saw that female is 2.5 times more dementic than the male. I don't know who will clarify this, the reason behind it. This is number one. And number two, again, you have mentioned that the single are more affected by dementia than those who is having married life. So these two are very important issue. And now, last but not the least, the third question is why this is more prevalent in the northern Bangladesh. So being a clinician, I worked in northern Bangladesh for a long time, almost more than 10 years. Is that related to, that is a highland or upland? So iodine deficiency is there, and more hypothyroid cases in the female I have seen as a clinician. Is there, can you do this in your next steps, that female relation with the iodine? And these are the clues that comes in my mind that I wanted to share with you. Otherwise, I think this was an excellent data and excellent work that you have done. And this will give a lot of issues in future that we are going to make for the geriatric, comprehensive geriatric assessment. We can incorporate your data, that this is our own data, not the international data, because it varies from race, it varies from country, it varies from every sets of population. Thank you very much. I am stopping here my comments, and I added a few words. If needed, I will join if time allows. Thank you very much. Thank you. Thank you for this study.
Dr.
Sir. Thank you, sir.
Dr. Gohil,
Sir.
may I respond to the very important question, epilepsy and dementia?
Yes, sir. Thank you, sir.
It's a very, very important question, because
Yes,
you know, epilepsy and dementia are very close and sometimes unparalleled. You know that, and they have a very strong relation. In fact, a demented patient is about, I think, about 10 to 15% more vulnerable to develop epilepsy rather than a non-demented patient. On the other hand, epilepsy may be a risk factor for dementia, particularly childhood major seizure. But the temporal epilepsy, what the question here asks about TLE and dementia, actually TLE causes amnesia, not really dementia. And I know you know the difference between amnesia and dementia. Amnesia is very transient, short-lasting memory loss, and dementia is a long-lasting progressive memory loss. So that is the difference and association. Thank you.
Thank you, sir, for your brilliant answer. Now I would like to request our teacher, Professor Badul sir, for his valuable comments. Professor Badul sir.
Thank you, Professor Jahir. Can you hear me?
Yes, sir.
This is an excellent presentation, and the honored chair and the chief guest from DG Health, they are the key person, particularly in the arena of the disposal of the health program. The key person of our ministry is DG Health, and for NCD program, Mr. Obed Amin is the competent man who is guiding us to help the NCD disease of the country. Today's discussion regarding dementia. Actually, the dementia is a problem all over the world, particularly the country like Bangladesh will face a tremendous problem. The year is coming, and the two excellent presenters exactly denoted how and what the problem is coming. My question is that as a clinician, and I think most of the neurologists now in the participation in our webinar, my humble submission is the one segment of the dementia, that is the clinical diagnosis of dementia. All over the world, particularly the developing world, overdiagnosis and underdiagnosis is a problem of dementia. For me, and I think Professor Anis and Professor Dean will agree with me, in our practicing, sometimes a patient's getting management of dementia, actually he is not suffering from dementia, and although he is getting, or some of the physicians has given that treatment of dementia and he is getting the treatment. And on the other hand, on the contrary, some people are suffering from dementia, although they are not suffering, actually they are not the patients of dementia. This is a very problematic because there is no dementia screening in Bangladesh. Not only that, who will treat dementia, yet it is not decided. It is psychiatrist, it is internist, it is neurologist, or a group of the doctors who will treat dementia, who will diagnose dementia, and how the management of dementia in a guideline. There is no such a discipline in this country yet. So my humble submission to Professor Obed Amin, as because he is in the chair, there should be a guideline. There should be a screening, a battery of tests to diagnose actually who is dementic and which person needs treatment. As because you know, there are some reversible cause of dementia, which does not necessary to treat the patient as a dementic. You will see my professor has already example has given hypothyroidism, subdural hematoma, stroke per se. Stroke per se, 25% of the patient may develop dementia at a later stage. And sometimes the treatable cause of dementia is extradural hematoma, structural brain lesion, particularly the brain tumor, and also depression. Depression, particularly the depression of COVID patient, they are suffering from the dementia, which is a reversible cause. So my question and my humble submission to the participant as well as the chair, that we must have a guideline to screening, to diagnose, and to manage the case of dementia. Particularly, the diagnosis is very important. If we misdiagnose a case of dementia, it will be harmful for the patients and the party, and as well as the society, that he is getting the treatment of dementia, which is very costly. So before giving or putting any person to a dementia, he should exclude the reversible cause of dementia, particularly thyroid, particularly vitamin deficiency, particularly structural lesions of the brain, and particularly the nutritional deficiency, and as well as depression. Thank you for patient sharing.
Thank you, sir, for your nice answer, nice comments. Now I would like to request Professor Dr. Abu Nasser Rizvi, Chairman, Head of Neurology, BNCU, and Secretary General, Society of Neurologists, Bangladesh.
Thank you, Dr. Joy. Honorable Chair, respected chief guest, special guest, panelist, and really excellent presentation made by the speakers and dear participants. Really, this is a very exciting evening, and the very topic is exactly very ignored topic, you see, among our neurologists also. So what Dr. Bodrul said, there are very important things. The diagnosis of the dementia, and this is very ignored chapter in the other areas. You see, even the lot of patients are getting the treatment of dementia, but they are suffering. They have sometimes as a delirium only. That was a reversible one, but they are getting the treatment of the dementia. And some of the dementia patient, they are treated as the insane, and they are giving the mental, uh, uh, they are giving the treatment for the as a mental patient. So this is very important to now make the awareness among the population, among the doctors about the dementia. That's because our life expectancy is increasing. And in future, around in our population, we have around more than 12% people are above 60 years, you see. So around we have 20 million people have some sort of dementia or milder form or some form of dementia. As, so as our age will increase, the people will increase. So this is the peak time. The Honorable DG sir is here, the key person for this and non-communicable disease director is here. They should take initiative to make the awareness of dementia among the people and also among the doctors by making seminars, posters, encouraging the NGOs for making up these things. And someone told, I think I just forgot, the dementic patient ignore. No, I have seen a lot of families. They come to us, the children. They are very much concerned for the parents, but not only the cost of the medicine, the cost of the caregiver is very important. And nowadays, having all the affection for the parents, but the time consuming for the children, they cannot help the parents in that way. And to keep the caregiver, they cannot afford some of the person, they cannot afford to give the caregiver for their parents. And as because it become very cost effective for them. So, and also the training of the caregiver is also important for dementia patient. I know only I heard about two NGOs are working. One is, one NGO is, they came one day, some Sir William Weaver's Foundation, and they are giving some home service, they told me, and they train up some health worker for training the caregiver for these things. And another NGO is Dementia Action Alliance. I heard about them, but yet I didn't visit them, or they didn't meet me. But I am requesting our very leader of our health profession to work on it, to make some training program among the doctors and also among the health workers, how they are going to train up the caregivers, and they make some health professional for give them training for train up the health caregivers so that they can treat them accurately. That's because it's a big burden for the family if they have a aged dementic patient in their home. They have all the affection for the patient, but they become helpless. That's because sometimes they go out of the home and they forget everything. They are lost. One of my patients, they came to me. They found his father in another Upajala. Some or others, they got some telephone number with some people. Kind enough, he called many, after calling many persons, they got the his home telephone number, and they came back with some his family members went there and bring her father back. They had all the affection for the for parents, but they are undone to provide the accurate caregivers. The affordability and trained caregivers is also not available in our country. So thank you very much for this nice evening. Thank you, everybody.
Thank you, Professor Rizvi sir, for your wonderful comments. Now, I would like to request Professor Hassanuzzaman for his valuable comments.
Thanks, Professor Johir. I'm very much privileged to get the chance to say something in front of this August gathering. Respected chair, special guest, chief guest, special guest, and dear audiences. Actually, this is a very marvelous presentation. We know very different things with aspects of dementia regarding the Bangladesh situation, which is very new to us because there is scarcity of works on dementia till date. So we are in risk. So the major goals of the dementia to treat reversible causes and to provide a comfort and support to the patient and caregiver. And when we think about the causes of dementia, we should first consider the reversible causes, suppose vitamin deficiencies, infections, NPH, thyroid problems, especially hypothyroidism, and CNS neoplasms, and especially drugs. So when we face the dementia, if we consider these reversible causes, then it will be beneficial. It will very much beneficial for the patient as well as the caregivers, because it will almost cure the dementia. But unfortunately, in many cases, we didn't get any. We don't get any reversible cause. Then we have to treat the patient symptomatically. And regarding the symptomatic management, I want to stress that in every cases, we should not go for the drug treatment, especially in the elder cases. Polypharmacy is itself a cause for dementia and delirium. So we should avoid the polypharmacy. And whenever we are treating a patient of dementia, we must look at the list of drugs, because many drugs which are used by the general physicians may cause worsening of the dementia condition. To another thing, I want to draw attention regarding the vitamin deficiency. In this region of Bangladesh, that is the southeastern part of Bangladesh, there is the prevalence of vitamin B1 deficiency, that is thiamine deficiency. We are getting a lot of patients, suspected patients of beriberi, also one is encephalopathy, and these we think that this is an important cause of dementia here. So we should take initiative to look at this matter, to study the cause, whether this is an important cause here, and if it is established, then we can treat this by supplementing the vitamin B1 to this area of people of this area. And other thing is the caregiver training, which is also addressed by my previous speaker. It's very important because in maximum cases, the family members and the caregivers are very frustrated, become frustrated due to the long course of this disease, and rewarding results will not come from this support. So we have to we have to train the caregivers properly And if the government take initiative to train up the doctors and also the other peoples related with these caregivers, then it will create benefit to the patients. Thank you very much.
Thank you, Professor Dr. Mohammad Hassanuzzaman, Head in Neurology Department, Chattogram Medical College. Thank you for your wonderful comments. Thanks to all the panelists and audience for the wonderful interactive sessions. Learned audience, now I would like to invite our special guest, Dr. Tamid Ahmed, Executive Director, ICDRB, for his valuable speech. Dr. Tamid Ahmed.
Assalamu alaikum. First of all, I would like to thank Professor Qazi Deen Mohammed for giving me the opportunity to join this very interesting seminar. Professor Deen Mohammed is a person, I must mention, who has made all the efforts to promote, neurology in this country. And I am sure that all of you are aware of that. I would like to thank the chief guest, Professor Abul Bashar Muhammad Khurshid Alam, for giving time, and also the chairperson, Professor Muhammad Robed Amin, a person who is now the right person in the right chair for taking care of the NCDs in this country. I was listening very carefully, and the first thing that I would like to point out is the excellent meta-analysis presented by Professor Blossom Stephens. And she mentioned that in several countries in the Northern Hemisphere, notably the United Kingdom, the USA, and Spain, if I remember correctly, the rates of dementia have come down. Perhaps we could benefit by looking at the possible causes, what made the rates go down. I know that Bangladesh is totally dissimilar from these countries, but perhaps reviewing the factors could help us in coming up with a solution for taking care of this huge problem in the community. I wanted to mention several things which Professor Tariqul Islam has so elegantly already highlighted. The 8% prevalence of dementia, which is shown by this survey, more of a burden in the northern districts. And I think this could also be related or associated with poverty. Then we have seen that those who are living alone without their spouses, they are more at risk of developing dementia. And finally, what alarms us is that within the next 20 years, the absolute number of people suffering from dementia in our country is going to double. This means that Professor Robed Amin, we have to help him in coming up with a solution, with a guideline. Now, we are talking about people who come to us with dementia. But I want to point out that most of the people with dementia, and we are talking about millions of people, they live in the communities, either in villages or in the cities, and many of them don't even have the opportunity of coming to a hospital. So we need to find out what we can do in terms of community management of dementia. And when I was listening to all of you, three things came to my mind. One is family mobilization, which is extremely important. Second is, community involvement, which is again very important. The role of our community leaders in the villages as well as in cities. And third, which I think when I go to my village home and I am accosted with this, our culture, in our culture, we do pay a lot of respect to our elders, but I think this is time to reinforce this. If we can have more of this respect, I don't know, but perhaps this can also go a long way in alleviating the manifestations of dementia. Professor Hassanuzzaman, I think he's the only one who raised the issue of nutrition as a very important element of dementia. And I want to bring to your attention the work that was done in 2014 in MATLAB, an ICDDRB study that showed a point prevalence of 12%. That study tried to look at what is associated with dementia. They found one thing which is very important: the role of malnutrition. People who are elderly, who are malnourished, they have a 6 times higher risk of suffering from dementia. So whether this is a cause or an effect, we don't know. But certainly, elderly people, when they suffer from malnutrition, they have sarcopenia. And when they have sarcopenia, we know that the likelihood of having a fall increases. And that increases the morbidity, the risk of fracture, and they die of it. So perhaps these are the things in the community that we should consider for having a national guideline for taking care of people with dementia in the community. Finally, I would like to thank wholeheartedly the elegant team that has done this survey, come up with this nationally representative survey results that we have today heard. I would like to thank Professor Malia Hakim, Dr. Alia Nahid, my colleague, and also other members of the team who have worked day and night under the very capable leadership of Professor Qaziddin Mohammed. Thank you very much once again for asking me to join this event. Thank you. Assalamu alaikum.
Thanks to Dr. Hamid Ahmed for his brilliant speech. Now I would like to draw attention to all the participants and dignitaries for short video speech of Professor Tudi to launch the Global Health Work Asia. Professor Tudi.
Important meeting today, and we are delighted to take part in this and also to help support the work of ICDDRB and the research teams across Bangladesh in this important therapeutic area. So I run an organisation called the Global Health Network in the University of Oxford, and we've worked with Alia and her team for several years now, and what we're trying to do is shift the effort and the approaches we've taken with this to work with our partners in the Global South. And so we've been working very closely with ICDDRB in Bangladesh. We're working with groups across Africa and Latin America, because what we want to do is shift the leadership and the coordination of the Global Health Network to key partners in the South. And what I'd like to do today is just explain why we're doing that and what we hope that means in terms of our...
And thank you again for asking me to join with you. And I hope that our NCDC program will incorporate the dementia as their any part of operational plan, so that in nationwide we can go for it and we can find out the causes, and we can actually provide care to our population. That should be the main aim of it. Okay, thank you so much. Thank you.
Thank you, sir, for your valuable remarks. I would like to remind audience that they can post their questions and can further communicate over email by contacting the organizers for further queries. Lastly, I would like to Professor Anisar for his valuable.
No, I don't want to. Can you have my video?
Yes.
It's not coming. If you have shortage of time, I can just avoid. I don't want to make any comment. If you have shortage of time, should I or just comment or just avoid? Jahid?
Sir, yes, sir. You can give your opinion, sir. Your comments.
Okay, just I was trying to say something. What actually Professor Robes, who is a very smart guy, I have listened to him. Very smart guy, he wisely has pointed out, we have missed the heading, I mean the title of the thing. That's why we have been asking lots of questions from various points of view as a clinician, as a physician how to diagnose, what to do, what is associated with usually, what are the risk factors, how to treat, etc. Robert Amin really very well explained what it is. I would say it is more of a public health issue. The study has been based to help the regulator like Robert what to do. Actually, there were lots of questions came into my mind when I first started listening to this, like everybody asked, like Professor Tariq, Professor Sabishu, Hassan Jamal, and epilepsy, etc. You can ask so many questions like that. What is etiology? What are the genes? What is the preclinical features? What are the antibodies now developing? What is the earliest preventive? How do you diagnose at earliest time by just taking your amyloid, beta amyloid from CSF and treat with autoimmune antibody? So there are lots of things that we will have like a science fiction. Only the disease will be this dementia if we cannot prevent, or the accident. So we will possibly conquer everything. So I'm not going to that. That's why I'm saying we can ask so many questions, but actually this is a study based on the public science. To exactly, it is, I would say it is rather a preliminary study to see what is going on. We don't know what answer. We don't normally know. What are the stages or what was the minimental score, whom they interviewed. There are life patterns for the whole life, or the singular bachelor or cigarette smoking habits, etc. Just during that interview, or it is a whole life pattern. So lots of questions come. So I would request it as just a preliminary study, and as Professor Stephen has mentioned several stages, so we will be doing more research. So I would say, Professor Din Mohammed, continue this and take more initiative to make it a research project on the basis of from clinical side by side, the demographic side. Thank you very much.
Thank you, sir, for your available comments. I would like to invite Professor Daniel D. Redford, Senior Director, Health Systems and Population Studies Division, ICDRB, for his vote of thanks.
Thank you very much. Thank you. I'm here to give the vote of thanks, and I think it's been such a wonderful seminar, and there are many people that need to be thanked. Bear with me a little. The chief guest, Professor Abul Bashir Mohammed Khurshid Alam, for his presence and his thoughtful comments. The two special guests, Dr. Tamid Ahmed from ICDDRB and Dr. Qazi Din Mohammed from the National Institutes of Neurosciences. The chairperson, Professor Robert Amin, was enormously important. I think getting the buy-in of DGHS and the fact that they were prepared to host this webinar was hugely important. Moving forward from data to actually doing more research and getting impact is enormously important. We had a great set of panelists, Dr. Qazi Tariq Islam, Dr. Abu Nazir Rizvi, Dr. Badrul Alam, and Dr. Mohammed Hassan Nuzman, who provided thoughtful comments that really moved the discussion along, I thought. I think I'd like to also thank you, Jaharul Haq, for your masterful moderation of the process. I think it's been quite a challenging process at times, but I'd like to thank the speakers. I think the speakers did a magnificent job of presenting the data. Professor Blossom Stefan presented the global data very nicely, and then Dr. Alia Nahid and Professor Maliha Hakim gave a very nice presentation on the Bangladesh data. I think having the first evidence from a national survey is hugely important for moving things forward. And I think I'd like to end by just thanking the audience for their attendance. We had in excess of 150 people attend, and it was a wonderful seminar. So thank you very much, everyone.
Thank you, Daniel Ritford, for your vote of thanks and remarks. Learned audience, thank you very much for your patient sharing and participating of this session. We can start our question and answer session for with our Dr. Alia Naid and Professor Malia Hakim, madam. If you have any query or questions, please ask the presenter.
Okay, I have some questions to be frank. Yeah. So Alia, I think you are the principal investigator, I guess, is that?
Yes.
So what was your instrument exactly? What was the instrument? How did you select the patient random? Okay, I understand that. And just above the age group, did you have any special interest? Because our likely 65 above age group is about roughly 8%. So and lots of questions. Let me ask one question first. How did you say this is a dementia? How did you pick up a demented patient?
Thank you for your question. I think this is a question coming from many people, how we did the sampling. So we basically tried to have divisional representation from the 7 administrative division in Bangladesh. So we actually identified one divisional rural cluster and one divisional urban cluster from all the 7 divisions at that time when we conducted the study. So it was a multi-stage random sampling method. So we have randomly selected one district, and then within the district, we randomly selected one sub-district. Within that sub-district, we randomly selected one union, and within a union, we randomly selected a village. So village was the lowest sampling unit for us for the rural areas. And for the urban areas, we actually identified the wards of the city corporations, and under each city corporation, we randomly selected one ward. So in that respect, we were unbiased in selecting our study site. And it is true that we may not have a representative of all the districts or all the sections of the country, but it gives us enough sample size to measure any comparison at the divisional level. Like we have sufficient sample size for getting the divisional estimates, sufficient sample size for getting estimates by sex. So this is very important. And the second thing was how we identified the dementia cases. I think this is a very important question. We used the mini-mental state scale for assessment, which has been validated in Bangladesh, and it was done in Bangla. It is the global recommendation for assessing MMSE, and we use that in the community. So we have to keep in mind that we were picking up these cases based on MMSE assessment in the community at their household. And we did a lot of reliability and validity testing in our own team as well. But I must admit that although MMSE is a recommended tool, but it is more aligned to a community who is more literate. And I think some of the learned audience actually also mentioned that about the literacy level. I think that was a question. So having a poor literacy in our community, it is sometimes difficult to get a right MMSE score. So it will be a very important research for us to use this evidence that we have collected from this first ever survey at the country level. So we really want to work together with the clinicians and other specialists to derive a locally appropriate customized screening tool for dementia. And it was the screening we did at the community level, and we then referred them to the neurology department. And this is how we have identified the cases. But there are disparity in discussion, disagreement among the clinicians.
I know, that's the question. So how did you define dementia? How did you differentiate between lots of comorbid, pseudo-dementia, I would say, than Alzheimer's or age-related or post-stroke, and so many questions are there. So could you just been able to differentiate these multiple coherent factors just to say this is a dementia, or just you wanted to know that the typical dementia means who cannot remember, or by definition, what is etc. So where did we stop? So I would say it will just give us a view. It could be psychogenic dementia, it could be any dementia. We did not know what exactly is. Just the apparent prevalence of dementia in the community, which you cannot exactly say that it is true dementia. What is true? Just to see what is the real prevalence of the people with a minimental score of below certain level. You decided, say, for example, 2016, something like that, or 26. So is it like that? We cannot clinically, it is not for clinical use, it is just for a public health screening. What is your idea?
Yes, yes, I agree with you. Yes, Lane, yes, Professor Anis, you're perfectly correct. Because this was a public health study, we really wanted to understand the community-based burden, to understand the epidemiology of dementia, and MMSC is a validated, globally validated scale to use in the community. In that sense, we did it correctly. But there will be question about how this can be clinically recognized, and that was not the objective of our study, but that may be the future study that Dr. Roberts said. So thank you very much for your comment. I think there are other questions from other audience. I'll be very happy to answer that. May I take the privilege of one question that Dr. Keith West asked about the differentiation across the division? And Dr. Talmid actually tried to give some explanation. There are a lot of theories. We really don't know what might be the reason of the regional variation in Bangladesh. In just one country, we see so much of variations. And this is something we need to research. And I want to assure Dr. Robert that what we presented today is actually the tip of iceberg. And we have more data available to us. We are going to analyze those data very comprehensively. And we agree that we should actually try to publish in a high impact journal so that we can actually share our report with other colleagues, and then we can identify some community-based intervention for preventing the risk factors. We cannot prevent dementia, but we may reduce the risk factors so that we can slow down the process and halt this progression to the level of severity. Thank you very much.
Thank you very much. Well, I like to just mention a few things that what Professor Anisulog was saying is very important. Important as because although we are trying this here as screening tool to make a say that the public health epidemiological perspective of diagnosing the dementia, but there will be always a big question of the pseudo dementia there. I totally agree with what he's saying. So I'm also asking at the same time the clinician, we have the brilliant looking of the Professor Bodul and himself, Professor Anis is there, Professor Kaji Tariqul Islam and Hassanuzzaman Rizvi sir is there. So there are always brilliant clinicians are there. I think you should come up also with this one, that can you predict few other scale to see whether there is a variations between the scale to make a diagnosis of the dementia. Like in India, I told you, they have done a geriatric scale, and then secondly, they choose a 10/66 scale, and then they again choose again the DSM-4 scale. So that you can have a rock curve at the end of the day, a rock curve, we can easily say the area under coverage to identify the sensitivity and specificity tool also to make a diagnostic tool for dementia for our country perspective. I think this will be wonderful study if our honorable teacher take the initiative. I think we can also be a good sponsor in this case, sir.
Yeah, Robert, it was Robert, isn't it?
Yes, sir.
Robert, you are talking. Sorry, it was Robert you are talking, isn't it?
Yes, sir. Yes, sir. Absolutely, sir.
Yeah, you are a very smart guy. I've been seeing you, noticing you for a couple of whole years. So I would say, yeah, that's good. There are so many points. First thing, let's start with Alia's point. Why the variation? You also raised this. We had iodine deficiency study, the ICCDR, Bangladesh, that's UNESCO. I was involved in that, where late 90s. So the northern part, some of the chord areas were low iodine areas where chance of hypothyroidism, which I don't know where that is linked to it. Still, there are socio-demographic, like Professor said, that there are so many socio-demographic issues or other things preventable or modifiable factors, which are factors. And third is, though Elia is saying it is a good number, scientifically it's a good number. So dementia definition have to be, and the tool have to be validated, de-validated, compared with MOCA or whatever it is. So many tools now. So we did this mini-mental score, some modification, like many illiterate, I would say illiterate, less literate people don't know who is our prime minister, where does he live, where is the where is Downing Street. Instead of that, what is the day to day, what is the time of the day now, what is that? These are all vague for lots of people. Secondly, the rate or the stage or the scoring, the level of scoring may not be true for everybody. So lots of issues. So I would say clinicians have to be involved actively, even for a socio-demographic study like that. So Badrul is nodding. Why don't? Okay, you have your participation have to be more collaborative. ICDDRB is a good center who has a background. They have cohort. They have low matlab or something. Matlab. Many areas. They will be helping. They will be of good help. I think you should be the principal investigator in some cases and take help of them. And statistical side, like all these things need to be multivariate regression or something to validate exactly there is a change or difference within this minimum number to say that yes, northern part or southern part has got some change. Whether this is due to the iodine level in sea surface or so many lots of things. It's a very interesting subject with a loads of branches come up. Rizvi, what do we have a dementia clinic? Everybody has dementia clinic. What have you done so far? Thank you. Robert can take lead. Thank you.
Sir, thank you. Thank you, sir, for your appreciation. Actually, we are already in the way to diagnose the dementia. We have a dementia clinic in our neuroscience, and every Thursday, number of people come and we are giving a screening test and as well as the battery of tests to diagnose the case of dementia. So I think your appreciation will guide us, and with the collaboration of ICDRB, we will give a fine pathway to demonstrate what percentage of patients is now remaining and which will be the diagnosis, earliest diagnosis. And Robert Amin and Professor Khurshid Alam give us some idea, because in this country, you know, there are a lot of hospitals for children, but there is one for the geriatric people or the dementia people. So the time has come to see the prevalence, to see the incidence, and to take care of the geriatric people, particularly the dementia people.
Any questions or comments, please, from audience?
Dr. Robert Amin, please take care, as because there is no hospital for dementic people to see for admission, and you know the neuroscience has given and taken the initiative to establish a corner of dementia. You know, there are proposed hospital is structuring now, and it is I think within 2 years it will be established, and we have proposed 50-bedded dementia corner in our hospital. So remember, in any setting where there is new hospital, you should give a corner for the dementic people, as because in 2040 you will see 2 million the burden of dementia people. And you know, the clustering of the family in our country is now in such a way that no one is giving such an importance to the dementic people. And you know, the son and daughter going abroad, only the geriatric people, particularly the dementic people in the house. So at last, government should take care. And you know, there are a lot of hospitals we can give some corner for the dementic people, either 10 or 15 bed or 5 bed at least.
Yes, sir. Thank you, sir. I think there's another issue of the subject of geriatric medicine. Very recently, our Bangladesh College of Physicians Surgeon has taken the initiative to make a geriatric medicine as a topic, because we need to have a geriatric specialist in our country to how to take care of this one. So this is a good, I would say, the initiative. And secondly, there was one geriatric unit developed in Dhaka Medical College. I think it was around 4 years back. And right now, government is also planning to make a geriatric unit every medical college that has been set up. So this is just a preliminary thinking, and your thoughtful idea will be also encourage us to give another initiative to carry on this one. Thank you, sir.
Thanks.
Yeah, thank you, sir, Professor Odamin, sir, for your valuable comments. Audience, thank you very much for your sharing and participating in scientific session. Thank you again. See you again another scientific session like dementia or like Alzheimer's disease or stroke or other thing with National Institute of Neuroscience, NCD and ICDRB. Thank you all again.
May I have the opportunity just before you leave? So I know a lot of clinicians are here, but what Dr. Robert just said, that a lot of geriatric medicine departments probably will be established. But as the public health physician or public health activist, our job is to prevent the disease to progress to that level that people need to come to geriatric ward. So this is the time to promote primary care and public health interventions in the community so that people will be aging. That is an advantage, and this is the indicator of the progress of the country. So people will be aging, but in our study you have seen that there are a lot of potential how these people can be productive in the society, and there are huge potential for prevention. And this is exactly what we NCDs are doing, and are so grateful to NCD control program that we are getting support in many ways. I think we, rather than thinking of piecemeal approaches, we should actually go for a comprehensive approach of understanding a condition, not from the clinical point of view, but from the societal perspective, looking at the social determinants, and try to bring all interdisciplinary experts to have a multi-component intervention. So we, as a part of ICDDRB, we will be very, very eager and proactively seeking your support and support of all the clinicians to help us design a robust intervention that we can test in the country and which can be a model for other low and middle income countries. So that is my appeal to everyone, including the public health specialists, clinicians, and the policymakers. Thank you very much for organizing this session for us. There are different organizations who are working in an older care, and there are certain groups who are youth mobilization, involved in youth mobilization. They took interest to work with us. So I'd like to request some representative, if they're still here, about the Dementia Care Foundation or other organization to tell us about their reflection about it. And the community mobilization youth groups, if you are also here, I would also like to hear your perspective, because I will be becoming older age person in 5 to 7 years. So it is my concern as well. So I will be older age people. So whatever our elderly are facing through, we'll be all facing that. So why not we try to help ourselves? And I think our burden is we need to involve our youth group and younger people to support community programs so that our elder people get good care, as Robert said, not cure, but the good care. So anyone from Dementia Care Foundation, UIDF or Medicine Club, I'll be very happy to hear your perspective. function of the
you can be very helpful. ICDDRB will be very helpful if clinicians plan something in collaboration with you. You may have all the baseline, base work, scientists, demographers, and they will just diagnose whether it is dementia or something else. That will be a help. You have many areas already, in the areas where you can do that. Yeah, I would encourage our clinicians to come forward. I have been encouraging them for over last 30 years, 40 years. Now they have clinics, set up clinics, but I can't say whether they're publishing from their whatever they are seeing regularly. I see some study, yeah, locally, but they should come forward with a particular maybe. Not even if you don't like demography, then you just do a particular thing. One thing.
We can see hand raised from Rashid Zorardi. Please, Rashid. Rashid, do you have a question?
No, I'd like to share. You said from Dementia Care Foundation. Yes. This is Rashid Sohrabdi from Dementia Care Foundation, Bangladesh. Thank you so much for this session, and I'd like to congratulate Dr. Alia Nahid Appa and Professor Maliha Appa for this very interesting and knowledge gathering session from Dementia Care Foundation. Congratulations. And as you know, Appa, that we are also working with this issue in Bangladesh since 2016 under the guidance of Professor Bin Mohammad Sir. He's the chairman of this foundation as well. So our focus is the community based, and Dementia Care Foundation is working with policy advocacy, raising awareness, especially capacity building for the dementia caregivers. And we would like to work with you, ICDDRB, NINS, and NIMH. So we hope that this issue, this initiative will go forward, and we'll always there to help these people in Bangladesh. Thank you all.
Thank you, Rashid. I'm just taking advantage of hearing any DYDF or Medicine Club, any youth group, or if there, or probably it is time to go home. It's been a long session. So Zahir, up to you. Over to you. Is there anybody? I didn't see any raised hands. So Rashid already spoke. Probably his hand is up by mistake. So if there is no question, probably we can request Zahir to finish. But I'd like to tell you that this study, I mean, working with the older people, experience was so sad. We actually learned more things than we have recorded in our survey forms. So these groups are really neglected. And if we don't do anything now, it will be the future Bangladesh. It will be our future. So I will urge that we actually adopt life cycle approach, and the way we are giving importance to our children, we also give importance to these older people who are really helpless. And only the government program can support them having a good life, which also reduce the burden of cost, burden of care, burden of the overwhelming health systems, and let them live a good life. Thank you very much from my side for everyone who participated in this session. And it was a brilliant discussion. And we learned a lot, particularly the scientists, we are involved in it. And I will carry all these messages to our team and the other teams. And as Dr. Trudy Lang announced this, the Global Health Network Asia has been launched today. So the Global Health Network Asia will not only work in ICDDRB alone. The objective would be to develop a network of hospitals with public health institutions in Bangladesh and link them with all of the similar institutions in the region in Asia, so that we can have a common knowledge shared at the very fast track, and we can find a solution for ourselves, and we give solution to the world. Thank you very much. I'm seeing my colleagues from Oxford University from the Global Health Network. Welcome to the session. We are almost finishing it. Sorry that you couldn't join us earlier, but please thank on behalf of us to Trudy for her wonderful delivery of the speech, and we will be celebrating launching of the Global Health Network Asia. So thank you very much. So I think it's time to say good night. Take care. Bye.
Thank you, Appa.